All right, everyone. Well, it's so nice to virtually meet you all, and I am super excited to give you this lecture today. Like she said, my name's Asia. I am a physician assistant. I work in Los Angeles. I'm in primary care, and we also do a lot of infectious disease as well with HIV and hepatitis. Those are kind of our two main infectious disease realms that we cover here. I have been in practice for about 2 years now. I graduated in 2018. I went to the University of Alabama at Birmingham for both undergraduate and PA school. I actually did a double master's program for PA school. So I did the dual physician assistant master's of public health program. And people have questions about that often. So I'm super happy to talk about it if anyone's interested in a dual program. What else? Yeah, that's about it. I saw some folks here from Birmingham, from Mississippi, so I'm always excited to see people from the Southeast. I don't get that a lot since moving to Los Angeles. So welcome, welcome. And I guess let's just hop right in. I was telling Nina and some of our team here that this presentation was pre-made. So this is a presentation that I often give to PA students and to medical students. So if you find that it's a little dense and it's a little too clinical, we talk about prescribing guidelines and dosages, and those are kind of things that, you might not need to know at this point. But, if at any point it's too much, just feel free to stop me. We can always skim over some things as needed. All right, so let's go ahead and get started. These are the things that we are going to talk about today. So terminology, barriers to care. The biggest portion of our talk is LGBTQ specific health concerns, and then inclusive practices for when you all are healthcare providers, how you can make our LGBTQ family members feel more comfortable, feel more welcome. So let's start off terminology 101. Again, some of this you may already know. A lot of these things have become a lot more mainstream, common knowledge nowadays, but not everyone does. So I'm just going to quickly, go over these slides. Pretty much all I'm trying to say here is that there's so many terms that people can use to describe themselves. And honestly, I don't really care that you know every single definition on this slide. I don't really care if you know what a sapiosexual is, but the most important thing to take away here is just that when someone discloses how they identify to you, just respect that. There's so many different ways you can identify, and again, the point here is just that there's lots and that we can always be respectful of the way someone identifies. If you do have questions about what these different terminology and words are meaning, I have a couple slides on that. There's too many to go through every single one individually, but we'll kind of brush over it. Gay rights, baby, I see it. Let's go. I see you in the chat. Next up, so pretty much this is basic, right? We all know what this is. So lesbians are women who are attracted to women, gay men are men who are attracted to men, bisexual, both men and women. And then a little bit, most people aren't as familiar with pansexuality or demisexuality. So those are some definitions for you there. Pansexuality, just pan meaning all or everyone, means people who have no real preference in terms of gender, orientation, or identity. So you're not limited in any way in your choices, I guess. And then a demisexual is a person, this is a more modern term that has come around, but I find a lot of people, even heterosexual people, will find that they actually identify as a little bit demisexual, and that is just someone who doesn't experience sexual attraction unless there's a really strong emotional connection that's been established first. So anyone can fall into that category. I feel a lot of people do without even noticing or realizing it. So I always like to point that out. Of course, there's also asexual, which is people who are just not, they have no sexual inclinations, no sexual attractions, no interest in sexual behaviors. That is a very real orientation, and that is, something to be aware of. Again, there's lots and lots of different terms that people use to identify themselves, but these are kind of some of the more common ones that you may see. Same thing here, my faves from Queer Eye. So queer is just an umbrella term. So some people, especially older folks, may find this term offensive. So it's not something that you want to call someone, but if someone self-identifies as queer, for example, I identify as a queer woman, that can be kind of an umbrella term for just any gender or sexual minority. Again, it's about how people identify themselves. So again, can be considered offensive, but I find that the community has kind of reclaimed that term, which is really nice and really empowering. Again, this may be something you already know. If so, I apologize, but I always want to point out the difference between gender identity and sexual orientation. So I want you to be able to think of these things as completely different things. They are not related to one another. Sexual orientation refers to who you are attracted to sexually in your partners. So are they men? Are they women? Both? Somewhere in between? So that's referring to your orientation, who you are attracted to, versus your gender identity. That's your concept of yourself. So how you see yourself as male, female, neither, both. So your identity refers to how you see yourself and how you present yourself versus your sexual orientation, which is who you are attracted to. Very good. To that term, gender identity and biological sex are not the same. They don't match up in some cases. So biological sex refers to your chromosomes. When, you're born and the doctor says, oh, it's a girl or it's a boy, that is your biological sex. So we talk about genitalia and your chromosomes and sex organs versus your gender, which is how you see yourself. And again, those things don't always match up. If they do match up and for example, I am a biological female, I identify as a woman, so that makes me a cis woman, versus, trans women or trans men who feel that their gender identity is not the same as what they were assigned at birth. There's also a lot of terminology that goes along with this that you may see. I should have put this on the slide, but you will see AFAB or AMAB, and what that stands for is assigned female at birth. So at birth, you were told you're a female, but that may not be the way that you identify. That's the easiest way to think about that. Again, transgender, we talked about a bit, is just someone who doesn't identify as their gender assigned at birth. And keep this in mind, though, being transgender does not imply any type of orientation. So you may be trans and you may be a heterosexual trans person or a bisexual trans person or a gay trans person. So, don't assume that, trans men or trans women automatically prefer the opposite sex. That may not be true. Remember, orientation is outward and who you are attracted to versus your inward identity. Gender transition. This is a term that it's a large term. It refers to the process by which people will try to make sure their presentation of themselves to the world matches the way that they feel on the inside. So some people will transition socially, and that's where you take on a preferred name. You may dress differently, wear makeup, grow your hair out, or not cut it. So social transition is the way that you present yourself in social situations. There's also physical transitions in which people can undergo surgery or hormone replacement. We're going to talk more about that as well as we get down to it. Some trans people choose not to undergo any type of transition, and we really shouldn't assume that anyone wants to. Just because someone identifies as trans doesn't necessarily mean that they want to be on hormones, that they want to change their name, that they want to have surgery. It's not required. It doesn't make someone any less trans. So that's something to keep in mind. Many trans people don't want to change their bodies and change their names or anything, which is, different strokes for different folks. This is just a dumb little graphic I found, but if you really want a list, like a comprehensive list of all the different terminology that the community uses to define themselves, this is a link. I'm happy to share these slides with you all after if you need them. So yeah, you can get a link there and see kind of a more comprehensive list of terms. So this is a question that I like to ask the audience, and feel free to type into the chat or not. If no one types in, I will not be offended. But when you think about accessing really good quality healthcare for LGBT folks, what are some things that might be barriers to that? Again, feel free to pop those in the chat box with your opinion. If no one wants to speak up, no pressure. Stigma, absolutely. Discrimination, homophobic, provider bias, rural areas. Oh my gosh. Kicked out and not having money, not ready to come out, laws. That's a really good one. Embarrassment, fear, judgment, absolutely. Certain, yes. So absolutely, all of these things that you are saying are absolutely true. You hit the nail on the head. Bias is a big one. Religion is a big one. Actually, just access. So many people, many providers aren't necessarily homophobic or transphobic, but they've not been educated on how to take care of these populations, and they don't feel that, comfortable with that. So that's something that these types of things hope to address, is that, by doing these types of things and these lectures, you'll feel more comfortable when it comes to your turn to treat patients. And I don't care where you are, rural Alabama, where I came from, or Los Angeles, you will treat and see trans folks, you will treat and see gay people. So it's really just basic healthcare that that people know. Yeah, I see no family support. I see conservative extremists. You're really onto something here. So yes, absolutely. You mentioned all of these things. I think every single last one of these topics was brought up. So health insurance coverage, limited legal protections, the laws, someone pointed out that, really, really good. Lack of education, no familial support, all of these things make it harder for LGBTQ folks to access really good care. You will see as we go on that LGBTQ people are more likely to have mental health disorders, anxiety, depression, attempt suicide. And the thought is that all of these different things, all of these barriers to care can lead to low self-esteem, social marginalization, which in turn can lead to risk behaviors that puts people more at risk for the things that we just talked about. So being gay or being trans by nature does not necessarily make one depressed, does not necessarily make one have low self-esteem, but it's all the societal things around that all of you just pointed out that are on this slide that can lead people to certain risk behaviors. This is not a blanket statement, but it's just kind of overall when we think of, why do LGBTQ folks, why do trans people, why do they struggle with mental health more so than our cis het companions? And it's all these reasons that you guys have already pointed out. So very good job. From a provider perspective, there's also barriers to care. So those that we just talked about were barriers to care from a patient perspective. From a provider perspective, how much education you get in your medical training is highly variable on where you live, where you train, what patient population you serve. And then there's also limited clinical research in this area. So, there's lots of nice guidelines and algorithms. That's not really the case when it comes to LGBT folks. So that's a barrier as well, and it's something that we have to take upon ourselves to address, which all of you have done today just by showing up today. So I'm really excited and really proud of everyone who came. Thank you so much. On to the specific health concerns, probably why you came here. So per definition, when we're in LGBT health, many of the concerns that we address are related to sexual health and sexual behaviors. That's just by definition. That's what makes a gay person or a lesbian person different from a heterosexual person is sexual behavior, right? So it's sexual behavior, not the orientation, that determines STI risk. So there's a lot of, beliefs or stereotypes that, gay men are more promiscuous and therefore we have to check them for HIV more often, or bisexual people may have more partners. It's not your sexual orientation. It's the behavior that determines your risk. So keep that in mind. And we kind of touched on this already. So mental health issues and other risks are specific to identity rather than your behavior. So that's just something I want you to keep in mind. A quick overview. So this is kind of the bread and butter. This is kind of the shadowing portion. I wish we could see real patients together, but these are the things that I treat and handle day in and day out here in our primary care clinic. So we're going to start with HIV and AIDS. Most of you probably know that gay and bisexual men are the most affected. Here's some stats for you. I don't want to read them to you off the slide, but in any LGBT practice, a big thing that you will probably manage, or at least need a good base of knowledge on, is HIV. Very, very prevalent in the community. Risk factors, again, probably you know this. Anal sex is the type of sex that is the most risky for contracting HIV, and that's just due to physiology and anatomy. You know, you get little micro tears in the mucosa. There's more chance for fluid contact, but of course you can still get it through vaginal sex as well. IV drug use, and one of the reasons that people may go undiagnosed is all those things that you already pointed out. You know, negative attitudes about homosexuality causes a lot of gay men, and not just men, but to not seek care, to not be tested for fear of discrimination. So you pointed those things out already, which means you're thinking about it. 38,000 new infections a year in the US. So this is an important thing. Anyone should be tested at least once a year, you know, unless you're just in the most monogamous relationship and you have been for 50 years and that person is monogamous too and whatnot. I mean, I don't know. But in general, what we do, even for our, you know, heterosexual patients, and we care for plenty of straight folks too, HIV test at least once a year. But I find that in our patient population, we test them about every 3 months, and we'll get into why that is once we get into the nitty-gritty a little bit more. This is the U.S. Health Department, the task force. These are their 4 goals to end the HIV epidemic. So we want to diagnose people as early as possible. It's important to get that early diagnosis because you don't want to catch someone after their condition has already progressed to AIDS. We'll talk about the difference in HIV and AIDS. So we want to diagnose people early on, right after transmission if possible, treat them. So we do what's called rapid start initiation, and that means when you get your positive HIV test, you are started on treatment as soon as possible. Nowadays, HIV treatment is so simple. You know, back in the day, in the early 80s and 90s, people were taking 20, 30 pills at a time, and you had a little timer to tell you when to take what, and still the outcomes were bad. Nowadays, HIV is easier to treat than diabetes, which people find surprising. Prevention. We're going to talk a lot about HIV prevention and PrEP. If you don't take away anything from this conversation today, I want you to know about PrEP and want you to know about PEP. So we're going to go on to that. This is our goal from HIV.gov. It's a national standard, national guideline to reduce new infections by 75% in 5 years and 90% in 10 years. So how are we going to do this? PrEP. This is a big part of what I do, a big part of what, you know, just kind of bread and butter healthcare, I feel. So I want anyone who's going to be a prescriber in the future to know about PrEP. Even if you're not an expert, just know that it exists and be able to talk to your patients about it. So PrEP is a medication. It stands for pre-exposure prophylaxis. You take it every single day and it prevents contracting HIV. It only prevents HIV. It doesn't prevent any other STIs. It doesn't prevent pregnancy, only prevents HIV. And it's a little bit of a commitment for patients because they prescribing guidelines require that they be seen every 3 months for labs. And I'll show you what those labs are going to look like. 2 drugs are approved from PrEP. There's Truvada. It's been around since 2012. It's approved for men and women, not just men take PrEP. Keep that in mind. Women are at risk as well. And now in 2019, in December of 2019, Descovy hit the market for PrEP. Now, Descovy is only approved for men because it was not studied in women. So just keep that in mind. If you have a woman on PrEP, Truvada is the drug. If you have a man on PrEP, it can be Truvada or Descovy. Descovy is basically Truvada 2.0. The pill's a little bit smaller, but if you look at these bottles here, and I don't know if you can see my pointer, but they're both made of the same medication, so emtricitabine and tenofovir. You'll see that on both bottles. However, the Truvada has tenofovir diproxyl fumarate, TDF, and it's dosed at 300 milligrams, versus the new PrEP, Descovy, is tenofovir alafenamide. Tenofovir alafenamide is uptaken a little easier by the body, so you can dose it smaller at 25 milligrams as opposed to 300 milligrams. So patients really like that. They like a smaller pill, less medication, less side effects. So approximately 150,000 people in the US are eligible for PrEP. Are on PrEP, but 1.2 million people are eligible. So out of 1 million people that are eligible, only about 10% are really taking it. And of those people who are taking it, it's really only in these kind of pockets of the country, you know, New York City, San Francisco, Los Angeles, Seattle, they're known for being more liberal, more urban, more gay people live here, that kind of thing. So where I'm from, rural Alabama, and not even just rural places, just there's tons of places here in California that that people can't get PrEP, and it's because either providers don't know about it, patients don't know to ask for it, and then some providers are opposed to PrEP and don't want to prescribe it, so they take the mindset that, you know, giving someone PrEP is going to then cause them to be more promiscuous, and that's something that we don't want. So, I mean, you know, that's not true. It's not a good reason not to prescribe someone PrEP, but that is the take that some people have. And it goes back to that stigma that we were talking about as well. Very good. In order to start PrEP, you must be HIV negative. That's pretty much the only requirement, is an HIV negative test, because if you are unknowingly HIV positive and you're started on PrEP, that's not a complete regimen, and it's not appropriate to treat HIV. So the two things you need to think about with PrEP are HIV and kidney status. Kidney status is going to be measured through a creatinine clearance, a BMP, or basic metabolic panel, that's going to show you the creatinine. As long as the creatinine is good, as long as the HIV test is negative, that person is eligible for PrEP. When you counsel your patients on PrEP, you want to let them know they have to take it for about a week, 5 to 7 days, before you get that therapeutic concentration and get reliable protection from HIV. Again, it's taken once daily. You want to encourage patients not to miss any doses. Now, if they reasonably miss a dose here or there, does that take away the protection? No, but it's best to take it every single day, and that's the way you want to pose it to your patients. But if they miss a dose or two, it's not the end of the world. It's all good. And then one of the good things about the 3-month follow-up is that you can screen them for STIs. So my PrEP patients, I see them every 3 months. We have a great relationship. I love to see them and see how they're doing, but I always test them for STIs. There's this phenomenon called the PrEP revolution, in which the HIV transmissions for certain places went way down because everyone's on PrEP. However, bacterial STIs, syphilis, gonorrhea, chlamydia, went way, way up. And the reason why is because people are not afraid of contracting HIV. They're not using condoms the way they were. Which is, you know, that's just what happens. It's kind of the same with birth control, the birth control revolution, sexual health revolution. It's the same thing that's happening here with PrEP. I'm seeing, I just switched back to the chat, and I'm seeing so many questions. I'll let the moderators decide. Should I keep going? Should I answer some questions?
We could do up to you, but do you want me to ask you the questions right now?
Let me see where I am in the slideshow. Okay, perfect. Let me do this slide, and then I'll take questions on PrEP and anything going forward. So just so you know, just in case any of you watching are thinking that maybe PrEP is good for you, you can now get PrEP free of charge through the federal government if you're uninsured. If you have insurance, your insurance should cover PrEP, but if you don't, you can get it for free through a government program called Ready, Set, PrEP. Great. Do you guys want to field some questions? Should I just go for it? How do you want to do it?
I could ask you the question.
Sure.
Does PrEP have age limits, like example for younger people?
No, there is no age limit on PrEP. It's studied in people, well, that's not true. So 18 years and older. I'm not sure if it's been studied in 17 years and younger. I personally have never prescribed it. I don't deal with in pediatrics or 18 years or younger, but I'm pretty sure it's only approved for 18 years or older. However, that may not be the case. I know there's lots of LGBT youth clinics, and there may be prescribing guidelines, kind of off label that I'm not aware of. But for me personally, I only prescribe to 18 and older. Sex education in Texas sucks. Sex education in Alabama as well.
Has there been any HIV infections in patients on PrEP?
That's an amazing question, and one that gets brought up all the time. So in people who, it's hard to confirm this, but in people who have taken the medication every single day as prescribed, no, as far as I know, and in all the data, all the literature, no one has seroconverted to an HIV positive status while on PrEP. But a lot of times people will go on vacation, they'll forget their bottles, they'll go 3-4 days without taking it, the protection level drops. And that's, at least in my experience, all of my patients who have been on PrEP who have been going on to contract HIV, which is not many, it was always a matter of what we call non-adherence. So they didn't take it every day and they skipped a couple days here and there, probably 3 or more at a time. The therapeutic concentration in the blood drops, and then you can establish that infection. I just saw, does Truvada have an effect on birth control medication? And that is such a good question. The answer is no, they can be taken together.
Oh, there's also a question if PrEP can be affected by hormonal treatment.
No, there's no evidence right now that suggests that PrEP interferes with hormone treatment in any way. I have several trans patients, both male to female, female to male, who are on PrEP, and it's absolutely not a problem.
Do you think that there should be more push for people to get tested for HIV? Is there still an issue of high HIV rate?
Yes. So testing is still something that needs better, proliferation, I guess you could say. So again, for us personally, we try to get everyone tested once a year. So if you see those patients, just once a year for their full physical and otherwise they're healthy and whatnot, HIV testing once a year is appropriate. However, lots of people aren't able to see their providers, or either the provider is not thinking, oh, this is a person at risk for HIV. So at one point in emergency departments, the HIV epidemic, one thing they tried to do to address it was whenever you go into an emergency department, no matter what, even if it's for a broken toe, they treat you or they test you for HIV. That's not happening anymore. There was like a whole insurance issue with it or whatever. But so yes, we do need more testing overall. And the rates of HIV, especially in what we call hotbeds, right now it's the Southeast. The Southeast has more HIV transmissions, new infections than any other place in the country. And a lot of those things that you all pointed out already, conservatism, kind of more of a religious Bible Belt type area, lack of education, lack of resources is what's contributing to that. Really great question.
There's another question in the chat. If the medicine is only for males, if it was a trans male, could they take it?
So good question. No, whenever, and we're going to talk about this a bit more kind of down on if we have the time, but when you're thinking of someone clinically, what medications they may take, what cancer screenings they need, you're going to think of the sex assigned at birth. So Descovy was not studied on assigned female at birth folks, only assigned male at birth folks. So even though the person identifies as male and will treat them as male, kind of, with their pronouns and everything else, they still have the female genetics assigned female at birth, and therefore they're not eligible for Descovy.
Okay, I'll ask last 2 questions in this part. How does PrEP affect the patient's kidneys, and why is the kidney function assessed regularly?
Yeah, you can. Yeah. So this is our MA Ed. We get tested for COVID every week. So I'm going to do my COVID test real quick.
That is kind of gross.
So we do oral COVID tests, oral or nasal. I like the oral, it doesn't hurt so much. So the question was,
How does PrEP affect the patient's kidney, and why is the kidney function assessed regularly?
Very good question. So Truvada, the TDF, tenofovir diproxyl fumarate, tenofovir is a known nephrotoxin. So it can be dangerous to the kidneys. However, that's why you do those every 3-month labs. So if ever you start to see a little bump in the creatinine, or maybe their filtration rate has gone down a little bit, those are the people that you stop PrEP. They should either be switched to Descovy if they're eligible, and if the kidney function is really bad, then you're not a candidate for PrEP. The tenofovir has been known to cause kidney toxicity, but that's the point of the lab. So before anyone ever sustained some type of long-term kidney damage or kidney failure, we would see that in their labs. I have not personally stopped anyone under the age of 65. I've had some older folks on PrEP. Yes, even people in their 70s are at risk for HIV. And sometimes, when you get a little older, chronic kidney disease issues, then they're no longer eligible. But most young people will take it just fine with no long-term damage. And again, it's all about monitoring. So if you do start to see bumps or little weirdness in their kidney labs, you might think to yourself, okay, we need to come off. Descovy was actually created to address this problem. So Descovy is less kidney toxic than Truvada, but not to the point that you don't have to monitor it. You still do.
Okay, last question for this part. Are these tests covered by insurance or typically paid for by the patient? I believe it's STD and HIV testing.
Yes, it is covered by insurance, absolutely. Now, again, insurance is a beast, right? Some plans decide they'll cover this and some they won't, and all But I would say the vast majority of insurance PrEP is covered. The labs are covered. It's kind of like a, I don't know, if you had to get labs for diabetes, or if you had to get labs for whatever other condition, it's covered under your insurance. STI testing is covered under your insurance as long as you do that 3-month period in between. So you can't recheck PrEP labs in 2 months. Insurance is going to say, no. But you can check STI tests in between, especially if a patient is symptomatic. So let's say I checked someone for STIs last week. It was all negative. This week, they now have some discharge and some burning. I'm totally going to retest them, and insurance is going to cover it. But that's something, it can always change a little bit based on plans. We work with this one company that only covers HIV testing once a year. That's not common, but, we know that's a thing. And so for those patients, we'll do the rapid finger stick HIV test instead of sending it to the lab. And then they can just pay, $10 or something for that, for the other 3 visits. So you can always find workarounds. Great. Should we keep going?
Yes, please. Thank you.
All right. I'm going to try to get through this quick. You guys have so many good questions. And so PrEP was the first thing I want you to understand. Happy to talk about it more in detail, but I really want to cover PEP. So PrEP is pre-exposure prophylaxis. PEP is post-exposure prophylaxis. So you can think of it this way. PrEP is like birth control, but for HIV. So birth control prevents you from getting pregnant. PrEP prevents you from getting HIV. PEP you can think of as like the plan B of HIV. So let's say you're not on PrEP, you had an unintended exposure, maybe, one night stand, or the condom broke, or if you're in healthcare, maybe you accidentally get a needle stick from an HIV positive person. That happens. IV drug users, that kind of thing. So anytime you feel, ooh, I may have been exposed to HIV, you can start PEP. It has to be started within 72 hours of exposure. And basically what PEP is a full HIV regimen, usually a 3-drug regimen. It's only 1 pill, but there's 3 drugs in that 1 pill. It's a full regimen, and you take it for 28 days or 30 days, make it easy for them, make it a month. And anyone who has been on PEP is clearly at risk and should be offered PrEP at the end. And so for PEP, you don't have to do any kind of labs or anything. You want to get them started as soon as possible. After that 72-hour window has passed, it's not really known if PEP is super effective. If someone comes to me and it's been 4 days, I'm going to put them on PEP because, I'm not just going to say, oh no, 72 hours has passed, so deal with it. But it may not be effective. It's not been studied that way. So 72 hours after exposure is that golden window. Anytime, it can be an hour after the event, but just within 72 hours. After you take PEP for the 30 days, you're going to return and get an HIV test to confirm that you did not contract HIV from the event. So that's something that you can get at an urgent care. Sometimes you can get it at health departments, Planned Parenthood, your primary care if they're up and with it. So I want you to know, and I want you to tell your future patients that even if the doctor or the PA or the nurse practitioner or whoever you're seeing, even if they don't know about PEP, you know about it and you can ask for it and your patients can ask for it. So it's a really great tool that we have at our disposal. And it's really changed the world in terms of HIV management. A lot of people find that they're not really that sexually active. They don't want to be on PrEP. They feel that they don't need it. But, things happen. And I have even taken PEP myself after an accidental needle stick. So it's not, there's lots of different reasons why one may want it. HIV. So people living with HIV lead normal, happy lives. So for example, let's say that I'm 26-year-old female, I'm diagnosed with HIV right now. My lifespan is going to be just the same as an HIV negative person. I'm probably going to be just as healthy. I'm going to live just as long. And what I'm going to do is I'm going to take one pill once a day, and I'm going to get my blood work done every 3 to 6 months. That's really the only difference in someone who's HIV positive if it's being treated appropriately. So again, back in the day, there were all these treatments, 20 pills a day, and people had horrible side effects. And now HIV treatment is so easy that the drug companies will fight over the pill size. So they'll bring you, pick my drug because the pill is smaller. When back in the day, side effects were worse than the disease itself. And now we're fighting over the size of the pill. So HIV treatment has come so far. It's really one of the most incredible stories in medicine. If you're interested in kind of the history of HIV, I can give you some resources and some great books. But HIV treatment with medication is like I said, one of our biggest accomplishments, and it changed the world. So treatment is simple, but treatment isn't the only thing you want to think about here. So we're also thinking about the social challenges. There's a huge stigma attached to HIV. Most people aren't very sure how it's transmitted or what your life will be like once you have it. Probably the biggest thing with HIV is it's a financial burden. HIV drugs are extremely expensive. I'm talking like $3,000 a month sometimes. And if you have no insurance, it can be difficult. If you do have insurance, but you have huge copays and huge deductibles, it can be difficult. I will say that there's so many programs for HIV medications in specific. There's the Ryan White Fund, health department. So HIV is one of those conditions that if you do not have insurance and you do not have money, you can still get your medications, but they may not be the brand new meds. You may not get that regular monitoring like you should. So that's a big issue is financial burden of HIV. And then also for our aging population, so we have patients who are referred to as long-term survivors. These are people in their 70s and 80s that were diagnosed with HIV back in the 80s and 90s when it was, almost a death sentence. So they have been on every drug, known to man. They've been on, cocktails of drugs, and a lot of those older drugs left long-term side effects, neuropathy, different fat distribution around the body. So those are all things that we have to deal with. It's a little bit more complicated to manage someone who's been living with HIV for a longer time versus someone who's a new diagnosis. HIV patients should be seen every 3 to 6 months. Sometimes, I have some patients who've had HIV for 20 years. They've been dealing with it for 20 years. I see them twice a year and they're great. They don't have any problems. It's all good. Other people we'll see every 3 months, especially folks who are a little bit not so compliant with their medications. It's nice to have that touch point with them just to kind of be in their mind. Hey, I'm thinking about you. I want you to take your meds. I want you to have good labs and that sort of thing. The two most important things that we're thinking about with HIV and the two most important labs we're going to be checking are the viral load. And viral load is how much of a virus is detected in the bloodstream. So undetectable viral load, anyone who has HIV, anyone who's treating HIV, our goal is to get that patient to undetectable. And undetectable means that there's so little virus circulating in the bloodstream that it literally cannot be detected by modern machinery. So let's say if you check, I'm HIV negative, if you check my viral load, it's going to be undetectable, right? Because I don't have it. And if you check someone who does have HIV and they're well suppressed, it's going to say the exact same thing, undetectable. There's nothing circulating in the bloodstream. So undetectable viral load is the primary goal of treatment. With medications, that's what you're hoping for. So at a new diagnosis or someone who's been off their meds, viral load can be even as high as the 9 million. So 9 million copies of HIV in the blood. Start them on medication, you can get them down to undetectable in like 2 months. Obviously, that depends on all different kinds of personal things and their other health conditions, but the medications we have are so effective that you can go from 9 million viral load to less than 30 in a matter of months. The other thing that's most important, or the second thing that's important with HIV is the CD4 cell count. And our T cell count or CD4 count is like a little snapshot of how well your immune system is functioning. As your HIV progression, or if it progresses, if you're not on medication, the number of those cells is going to decline. And the difference in HIV and AIDS is the T cell count, the CD4 count. So if your T cells drop below 200, then technically you have the diagnosis of AIDS. It may not be known to a lot of people that HIV and AIDS you can go back and forth between having HIV and AIDS. So let's say you have HIV. By the time we catch it, your T cells are down to 100 or your CD4 cells are down to 100. That person technically has AIDS at that point. However, they get on medication, the T cells come up, the viral load goes down, and now you're back into the HIV range. So the only difference in HIV and true AIDS is the T cell count. The normal range for T cells is about 500 to 1500, and people who are on medications daily, they have, probably T cells better than mine. So if someone is suppressed, if they're undetectable and their T cells are above 200, preferably a little higher, up into the 500s, their immune system functions just like anybody else's. I tell people, like, your immune system is just as good as anyone else's, especially if the CD4 is normal, the viral load is undetectable. You're not further at risk for opportunistic infections, that kind of thing. Now, if the T cells are below 200, this isn't on the slide, but it's good to know, anyone with T cells under 200, anyone who has AIDS should be on antibiotics every single day, prophylactic antibiotics, and that prevents conditions like PCP pneumonia, oral thrush, or yeast infections in the mouth and genitals. And so when you have AIDS, the immune system is unable to fight things off. So a cold can turn into, pneumonia and that kind of thing. So we keep them on antibiotics every single day to prevent that. Once the T cells come up, they're above 200, then you're kind of in the clear and they can come off their antibiotics. Here's another big point. Please put this in the quiz. It's so important. So we say that U equals U. Undetectable means untransmittable. So someone who has HIV with an undetectable viral load cannot transmit it. So I don't care if you're having unprotected sex, I don't care if you're sharing needles, if they're undetectable, you cannot give it to someone else. And this is so important. This is why we strive so hard for that undetectable status, because there's no risk of transmission. I think that's a good place to stop, as I'm sure there are questions. So I'm going to hop back over to the chat. Up to you. I can continue, or we can take some questions. What do you think?
We actually have a lot of questions. I can ask them right now.
Okay.
What is the likelihood of someone contracting HIV after being on PEP?
After being on PEP. So if you, let's say that the person or you had a needle stick, that's an easy example. And you get on PEP within 72 hours and you take it every day for the full 30 days, the chance, I'm never going to say zero because, freaky things can happen, but it's basically zero. Of people who have have contracted HIV, at the end of the 30 days, we check an HIV test and it's positive. Usually they either started the PEP too late or they didn't take it daily. Medication adherence is going to be one of the most important things that you'll ever deal with in your life, whether it's an HIV patient, a diabetes patient, it's just getting people to take that pill once a day, every day. It's harder than you think.
Even though PEP is to be used on patients after an exposure, could a patient use PEP as the preventative treatment? Sorry.
No, not really. So PrEP is the pre-exposure. PrEP is prevention. So, I guess you can kind of think of, I have patients who, will have an exposure and then they'll start PEP and then next month it happens again. And at that point, am I going to deny someone PEP? Never, never, never. But I'm really pushing those people to get on PrEP. It's way better than PEP because you prevent it before it even happens, as opposed to trying to like, oh my God, has it been 3 days? I don't know. So no, you really shouldn't use PEP as prevention because there's already a drug for that.
How are mutated strain of HIV approached because it has drug resistance?
Can you say it again?
Oh, how are mutated strain of HIV approached because it has drug resistance?
Hold on, I'm going to look for this question because I can't understand you. I'm sorry.
Sorry. I'll put it in the chat.
Okay, yeah.
The question is, how are new strains of HIV approached, especially when they build up tolerance?
Or resistance. The question is about resistance. I understand. How are mutated strains? Oh, okay, perfect. Really good question. So honestly, regardless of what strain you have, there's going to be a medication. There's tons of HIV medications. And so one thing that you can do when you get a new diagnosis or you get a new patient that may be failing their regimen or they're still detectable and you don't know why, is you run what's called a GeneAssure archive. And that takes the virus and it shows you all the different kinds of mutations. There's so many that you can have. One of the big ones that we think about is called M184V. That is a mutation that can make the HIV harder to treat. But when you take that test, it also shows you what drugs that their particular virus is sensitive to. So you'll get a big sheet and it's got all these HIV drugs on it and you'll see resistant. You can't use those medicines. It's very rare that someone is resistant to everything. And if they are, that is what you call a salvage patient. And there's drugs for that. Usually they're IV infusions that they'll get once a week, but it can still be treated. Even if you're resistant to all of the oral medications, again, that is not very common. But if you do have a salvage patient who's resistant to everything, the virus is mutated, you can start them on IV infusions of different medications to treat.
How do you remember all the drugs you prescribe? Do you often have to look them up, or do you just learn them over time?
Yeah, good question. So it just depends, especially when you first get started. It's difficult to remember. I have lots of resources. I can grab them and show them to you if you want, but sometimes, like if it's a drug I don't use that often, I'll have to look it up and like maybe up to date or something like that. But I find, especially once you kind of get your practice going, the patients, your clientele, there comes kind of like a little, 10 drugs, especially with HIV, that you just learn. So in the beginning, it's a lot of looking up. And if you're unfamiliar with the drug, there's so many resources. You do not have to remember all this off the top of your head. Eventually, it gets kind of ingrained in there and you just know it. But especially when you first get started, like, ooh, I don't remember what labs to check, or I don't remember, if this drug is once a day or twice a day and stuff like that, you can just look that up. You don't have to remember it off the top of your head, though likely you will.
Do you think that HIV positive people would have a worse insurance, which makes it more difficult to get their treatment?
That is a good question. And it depends. So some people have crappy insurance, some people have great insurance, and it really makes a difference on what they can get drug wise. But I will say, like I said, HIV is one of those conditions that there's so many national programs for that you can get the medication even if you don't have insurance or don't have good insurance. What was the other part of the question?
Oh, that makes it harder for them to seek treatment.
Oh, that makes it harder. Yeah. Yeah. So insurance issues is going to make it harder to seek treatment for anything, a broken toe, HIV, whatever. So yes, insurance can very much affect the quality of care and where you can go. So for example, our clinic, obviously everyone's different. We only take certain types of insurances. We're only in network with these few, blah, blah, blah. So it's just so dependent on each individual plan and each individual clinic. Quickly, I saw a really good question that says, undetectable does not mean that the person has been cured from HIV, right? That's correct. There is no cure for HIV, but they think it's coming. Research says that probably within our lifetimes, in the next 10 to 20 years, we're going to have a cure for HIV. So cure trials are ongoing. They're looking good, but as of now, we do not have a cure. And undetectable, you still are HIV positive. You still have it, but it's not circulating in your blood. It's not causing you harm, and you can't transmit it.
Just like how HPV can lead to certain cancers, has there been any research on HIV leading to any types of cancers?
Yes, there is one cancer that is specific to HIV and really more so AIDS. You kind of have to be in that AIDS range before you start developing this, but it's called Kaposi sarcoma. And that is a cancer found almost exclusively in HIV or AIDS, really. And it's derived from muscle tissues. And the way that it looks, you can do a quick Google, but it's like these dark purple plaques. Sometimes it's on the skin, sometimes it's around the genitals. It can even be in the mouth. But it's called Kaposi sarcoma, and it's pretty much only seen in HIV. Also, if you are not being well treated for HIV and you have AIDS or a compromised immune status, you're more susceptible to anything. You can't fight off, your body is less able to kill those precancerous cells, and they're more likely to turn into cancer.
Would you get more medication if you have AIDS?
No, the only thing you would get different with AIDS, remember, is that daily antibiotic. Okay, I'm going to keep going.
Okay.
Because I think we probably have some more interesting topics. I'm going to make it quick, though, with the gonorrhea, chlamydia, and all that. That's not that exciting. But for the sake of time, I really want to touch on trans issues. Is that okay? Great.
That would be good.
Okay, hepatitis. I think for time's sake, I'm going to skip these. Again, I will share these slides with you all. I just ask that you please don't use them without notifying me or crediting me. I spent a lot of time on these. I know you won't, but just, whatever. If you want to know about hepatitis, I'll give you these slides. But I think for time's sake, there's more important things to look at. Bacterial STIs, again, we talked about the PrEP revolution. STIs are up, everywhere. And what I want you to know, the only thing I want you to know here is that if you walk into a regular urgent care and you say, hey, I need an HIV or an STD test, most likely they're going to give you a cup to pee in and go about your way. But you can have gonorrhea, chlamydia in the urine, so in the urethra for men and in the vagina for women. You can also have it in the throat and rectal. And it all just depends on what is touching what. So for me, a full STD screening depends on what kind of sex you're having. If you're having oral sex, I'm going to swab your throat. If you're having anal sex, I'm going to swab your butt. And then pretty much everyone gets swabbed or leaves a urine sample. So just keep that in mind. Gonorrhea, chlamydia is not only in the vagina or the penis. It can also be in the throat and rectum. You got to swab them. You got to ask the right questions, because no patient pretty much is going to be like, hey, can you swab my butt? No, you have to offer. Syphilis. Syphilis is, when I was in school, they told us like, oh, you'll never see this. It's like a, medieval disease. We see so much syphilis, it's not even funny. In our clinic, it's so prevalent that we have this joke that any rash is syphilis until we prove it otherwise. Syphilis is called the great pretender because it can take up to 90 days for the test to turn positive. So let's say you have a one-night stand last week, and then you come this week and you get tested for STIs and it's all negative. You're technically not off the hook because it can take a while, up to 3 months, before the syphilis test will turn positive. A lot of times you have no symptoms of syphilis. Common symptoms are a full body rash, and it starts on the body and tends to spread outwards. It's not really itchy. I encourage you to Google syphilis rash so you can see what it looks like. And then also ulcers in the vagina, on the penis, in the rectum. I don't think I've ever seen one in the throat, but I imagine it's possible. And the thing is about those is that they do not hurt. So that's almost like a classic syphilitic ulcer, is like this ulcer, and you would think it hurts, but it doesn't. And that too will go away on its own. So sometimes people will get a rash and then in a week it goes away. The ulcer goes away, you know, a few days, and people don't think anything of it because it went away, but really it was a syphilis infection. And syphilis that goes untreated for a long amount of time can actually progress into neurosyphilis and get into the brain, which is deadly. It was thought that a lot of leaders, world leaders, and people throughout history had syphilis. So there is a conspiracy, I'm not sure if it's true, that Hitler actually had syphilis, and it contributed to the end of his life when he kind of, I mean, obviously he was crazy the whole time, but he got crazier towards the end of his life, and a lot of historians think that he actually had neurosyphilis. So that's a little fun fact. Syphilis is very easily treated. All of these bacterial STIs, so bacterial STIs, the gonorrhea, chlamydia, and the syphilis, easily treated with antibiotics. So it's one of those things that can be cured. Take your antibiotics, get your shot of penicillin, and you're cured. STIs that people don't really think about are things like Shigella, Campylobacter, Giardia, those gut bugs that give you real bad diarrhea. And the reason no one really thinks about it as an STI is because, you know, it's a little bit questionable, I guess, for some folks how you got it. But I'm just going to say this. Anytime you are around the butt area and have the chance to get fecal material in the mouth, and again, it's not like you're not going to notice this. It's all microscopic. So, you know, take that as you may. You can get Shigella, Campylobacter, Giardia, those kinds of things. And so whenever someone has diarrhea, we always swab them for these things. And a lot of times they're transmitted sexually, but we can always say it was the salad bar or something like that. Or maybe you took a trip to Mexico. I don't know. Also, mycoplasma. Mycoplasma is a bacterial STI that mimics a urinary tract infection. So sometimes you'll check a urine sample or you'll check gonorrhea, chlamydia, and it's negative, and you know, the person is still having burning, or you're still seeing some white blood cells in the urine, and it'll turn out to be mycoplasma. Mycoplasma is very common, very easily treated, and it kind of just lives in the urinary tract sometimes. So it's often not a problem, but it can overgrow. And when it overgrows, you need to treat it because the patient's often symptomatic. Lesbians can transmit STIs. So there's a, actually this happened to me one time in college, in a public health class. You know, we were talking about STIs and someone said something about, well, what about lesbians? And the teacher goes, well, lesbians don't really give each other STIs. And I was like, in what world? So it's true that there's less STIs in the lesbian population, and that's honestly anatomical. There's less actual penetration of mucous membranes, and you know that leads to less cases. But women can give each other, two women can give each other gonorrhea, chlamydia, HPV, herpes. So offer screening to lesbian and bisexual women on the same basis as a heterosexual woman. And then also this goes for both lesbians and anybody who are going to be using sex toys, but you can also transmit STIs through sex toys and through douches and through anything that goes inside you, right? So sometimes we'll have someone, we treat them for, say, chlamydia, and then it comes back positive again, and they say, well, I haven't had sex with anyone, you know, I don't know what it was, and it was a toy. So sometimes toys are not properly sterilized, especially like jelly or plastic toys. They really harbor bacteria and can reinfect you. So I tell people to use condoms. If you're using toys, use a condom over it. That way you can just take the condom off and then the toy is clean. If you don't want to use condoms, you can use them, you know, by themselves, but I recommend using silicone or stainless steel or glass or something that you can sterilize. I tell people to put them in the dishwasher. I don't know if you have roommates or not. I don't know if they'd appreciate that, but that's an easy way to sterilize them, is either drop them in some boiling water real quick, put a condom on them, or just throw them in your dishwasher. So that's always fun when someone opens the dishwasher and there's a big, toy in there. Cool. Let's actually keep going because this is quick and super important. And then I'll take some questions and we'll finish up with transgender medicine. The one thing I want you to know about HPV is that it's so very common. If you line up 10 people on the wall, 9.5 of them are going to have HPV at some point in their lives. There's over 100 different strains. It's spread through skin-to-skin contact, so there doesn't have to be any type of penetration to contract HPV. And HPV is honestly not a huge deal unless it turns cancerous. So HPV can cause cervical cancer, throat cancer, anal cancer, and penile cancer. But in your standard education, we're only taught about cervical pap smears. But you also need to do anal pap smears for anyone who is having anal sex. So that can be women, that can be men. You want to ask, when you take your patient's history, are you having anal sex? Because if they are, they need an anal pap smear as well. So HPV doesn't discriminate. It can cause cancer anywhere. And yeah.
disease
I'm sorry, I can't understand you. I don't know if that's a question for me, but I'm gonna keep going. If it's a question, can you please drop it in the chat?
I unmute myself, sorry.
Oh, that's okay. Yeah, so an anal pap smear, we all know kind of about cervical pap smears, right? You get the speculum and it's real uncomfortable, and you take the sample from the cervix. So women need that about every 3 years or yearly, depending on HPV status and their last pap smear. But people don't really think about anal pap smears, so be sure you're asking patients that question. Some actual really famous celebrities have died of anal cancers, and it's because no one ever thought to check them there for HPV. And the most famous one, I forgot her name, but I'll remember it and I'll tell you. So yeah, point of the story here is do both anal paps and cervical paps for anyone having anal sex or vaginal sex. We don't really screen the throat that often. It's not as common to contract HPV in the throat, but it's thought, and well, it's known that about 80% of all throat cancers are related to HPV. So there is a test if you're concerned about it. If you see a lesion or someone's very sexually active and there's concern, where you gargle some water and you spit it in a cup, and then the cup is sent to the lab and they check it for HPV. But that's not a routine practice. Maybe one day it will be. It really wouldn't be a bad idea. This year, the CDC changed the recommendation for HPV vaccination to include everybody from 9 years old to 45 years old. So the Gardasil vaccine is going to prevent 9 strains of HPV that cause cancer. So the 9 most carcinogenic strains. The question is that people will ask is, so I got the Gardasil shot, but I still got HPV. You can get any of the hundreds of strains of HPV, but with this vaccine, you won't get the 9 strains that are most likely to cause cancer. So the reason we started at age 9 is because ideally it's best to get it before you're ever sexually active, because if you get it at age 30, you might already have one of those 9 strains. It's because, just because you have one doesn't mean you want the rest. So, it's absolutely available. A lot of people say, a lot of my patients are like, 48, and they're like, well, I'm still having sex. Can I get the Gardasil vaccine? Absolutely. You can get it at any age, but the CDC recommendation is basically lesbians get screened less. They don't have pap smears as often because there's people out there who think they don't need them because they're having sex with women and not men. That's not true. Please don't be that person. We can skip this. It's not super important. The story here is just to screen lesbians the same as heterosexual women. Same thing here. Many lesbians have had or will have male sexual partners in their lifetime. HPV can be transmitted between two women. And also lesbians are at an increased risk of ovarian and endometrial cancers, not due to sexual activity, but because they are less likely than heterosexual women to ever be pregnant, and they're less likely to have ever used birth control over their lifetime. So this is a funny story, but when I was in high school going into college, I was still in Alabama, and my doctor prescribed me birth control. So he goes, "Are you sexually active?" I'm like, "Yes." And he's like, "Oh my gosh, you need to be on birth control." And I was so afraid to say that I didn't because I was with women that I took the prescription, and I even filled it at the pharmacy for 2 years. I didn't take it, but I filled it because I was afraid that he would see that I wasn't. I don't know. So yeah, that's just a little funny story. I paid for birth control for 2 years, even though I didn't need it. Talk about the stigma. So these are just some things to know about lesbian health. And probably the last thing that we'll talk about today is trans health. We have about 30 minutes left. We can go over a little bit if we need to, but obviously we cannot discuss all the nuances of trans health in 30 minutes. So I'll leave it up to you all if you want to ask some questions before we go on.
I think it would be better to hear this first because I feel like it's important.
You want to go ahead through? Let's go through.
Yeah.
And then I'll try to leave some time at the end. All right. So back in the day, identifying as transgender was considered a mental illness, and it was even in the DSM and everything. And it's actually still in the DSM, but in 2022, the International Statistical Classification of Diseases, so the DSM, is going to take away that transgender or gender incongruence is a mental illness because we no longer identify it as such, and that will go away in 2022. Yay! Quickly, there's much more physical and sexual violence against trans women, specifically Black trans women. It's actually considered a public health crisis because Black trans women are being killed at a 7 times higher rate than the general population. Also, there's higher rates of suicide and suicide attempt, mostly because of discrimination, stigma, gender dysphoria that's not able to be addressed. So these are kind of the mental health issues and the physical safety concerns when it comes to our transgender patients. So this goes back to that person who said, if someone's a trans person, do they get Descovy or Truvada? So you want to get a surgical history on your transgender patients, and their assigned sex at birth is what's going to determine what type of screening they need. So for example, let's say you have a male to female transgender person, but they have not undergone orchiectomy, they have not undergone prostatectomy, so they still have testicles, they still have a prostate, and therefore you still have to screen those testicles and screen those prostates for cancer. So just because they identify as a female, you're going to treat them as such, except for when it comes to cancer screenings, and that's just based on anatomy. So if you have testicles, they're going to get screened for cancer. If you have a prostate, they're going to be screened for cancer, and the same goes vice versa. So female to male patients, if they've not undergone mastectomy or breast removal, you still have to do mammograms and breast exams because they can still get breast cancer, and the same thing for the cervical cancer. So some trans folks will undergo total hysterectomy where the uterus and the cervix is removed. In that case, there's nothing to screen and you don't have to, but a lot of times people keep their uterus, they keep their cervix, and so you still have to do pap smears and screen the cervix for cancer. This can sometimes result in a lot of dysphoria for patients. They kind of don't want to be invaded in that way, but that's when you build a good relationship with your patients and just, they get to a point where they trust you and you can do those screenings for them. So yes, that is a really important part of trans health. So I call it like a organ database, so organ bank kind of. So I ask people, do you still have testicles? Do you still have a prostate? Do you still have breasts? Do you still have a cervix? And that way I know what they need to be screened for, and I don't have to do it in a way that can cause them any type of dysphoria or hopefully with as little discomfort in that range as possible. Hormones. So pretty much hormone therapy is made out to be this very difficult thing to manage, and in reality it's not. So a practical target for hormone therapy is physiologic ranges for a cis man. So if I have a trans man, female to male, I want to keep his hormones and his testosterone levels around the same range that I would for a cisgender man. So that is between 300 and 1,000, give or take, a little bit is fine. But yeah, I want to keep them at the same, I want to keep them as close to physiologically normal or within range as possible. And the same thing for trans women. So male to female women, I want to keep their estrogen ranges around 200, a little bit under 200. We're the same for cis women. And then in a male to female transition, sometimes you have to decrease testosterone levels with anti-androgenic medication. So going from female to male, all you have to give is testosterone. You don't have to suppress the estrogen. But going from male to female, at first, at least, a lot of times you have to suppress the testosterone and then give estrogen on top of that. Now, after they've been on estrogen for quite a while, some will choose to come off the anti-androgenic or the testosterone suppressing agent. And it's just, you take it on a case-by-case basis based on what are they looking like? What are they feeling like? Are they getting the effects that they want? So for trans men, is that facial hair growing? Is the voice getting deep? Are they putting on muscle mass in different places? Vice versa for male to female, is there breast development? Is there, redistribution of fat around the hips? That kind of thing. There's no real wrong way to do it. You don't want to keep their levels way too high, like supra physiologic. So, if you've got someone's testosterone up in the 1500s, that's not good for anybody. So, but in terms of where you should be in that range, I let the patients tell me. As long as their blood counts and their labs are okay, they're not in any kind of danger, I'm always willing to go up or down based on the effect that they want to see in themselves. These are some options for testosterone. You can inject it, or you can use a patch, or you can use transdermal gels. Lots of options. And what you need to monitor for female to male trans folks on hormone therapy, I check their labs about every 3 to 6 months at first. And then as they've been on hormones for quite some time, we can go to a yearly basis. Again, I talked about kind of those practical target ranges. These are kind of the slides that I feel maybe a little bit too much. I mean, I don't know, maybe not. But with testosterone, the biggest thing you want to monitor are the blood counts, because testosterone use tells the body to make more red blood cells. And you can get an increase in hemoglobin and hematocrit. That's called secondary polycythemia. And it puts the patients at risk for blood clotting because the blood is just too thick, because there's too much red blood cells. And that happens also in cis men on testosterone. Anyone on testosterone, you need to monitor their CBC or their blood counts to make sure they're not too high. Going the other way, female to male, these are what I was telling you about, the anti-androgen agents. Most often we use spironolactone. Spironolactone is used for lots of different things. It's also used for acne, and acne is a lot of times due to testosterone dominance. So even non-trans people can take spironolactone. But it suppresses testosterone, and then there's lots of options for estrogen, same deal, oral estrogen, injectable estrogen, and then estrogen patches. And you can see the doses that is appropriate. I don't think that's too important for you to know at this point, but maybe one day. This is monitoring. It's very similar, the same every 6 to 12 months. 3 months in the first year. Again, you're monitoring for those physiologic ranges. You don't want the testosterone to be high. You don't want the estrogen to be too high. And then also when with estrogen, you want to monitor prolactin and triglyceride levels as well. And also potassium if the person is taking spironolactone. Spironolactone is a diuretic, and it causes you to pee a little bit more and can mess up your levels of potassium. It's not very common that I ever see anyone with potassium issues due to spironolactone, but it can happen, and it's one of those things we watch out for. Mental health, I think we all kind of know this. We talked about it. They're twice as likely as heterosexual adults to have a mental health condition. To have a mental health condition, it can be hard to find a provider. Suicide, we talked about. I don't want to waste too much time on that. Other things that influence mental health are things that we've already talked about. Hate crimes, families, you may have come from a conservative area of the country, all these kinds of things. And then one thing I'd like to point out is that rates of domestic violence among same-sex couples are pretty much the same as heterosexual couples, but we're screened for it so much less. So people don't really think of like two men, if you've got two men in a couple and one beats the other one up, a lot of times people aren't thinking of that as being domestic violence or abuse, but it is. So keep that in mind whenever you're screening someone for possible unsafe situations at home, that there can be domestic violence between same-sex couples just as easily as heterosexual couples, but it gets lots less attention and sometimes it goes unnoticed for longer. Perfect. These are my last few slides, and then we have a good bit of time for some questions. So these are just some inclusive practices that you can take. Safe space visual cues. It's always comforting when you go to a doctor's office and they have a little rainbow flag in the window. We love it. Putting yourself as LGBTQ friendly in any advertisements. At one point, we wore these little pins that said Asia, she, her. So outwardly expressing your pronouns first makes it so much more likely for a person to feel comfortable telling you theirs. You want to have gender neutral restroom options, and then also use terms like partner or spouse instead of husband or wife. And instead of mom and dad on your forms, you can say parent one, parent two, just in case there's two moms with a kid. That's more for pediatrics, but it's still nice to have. So these are just things that make it easier. We also use intake forms. So all the time, you'll fill out a form and it's like male or female. Well, some people don't identify as male or female. So what we do is use a blank space. So for gender, for preferred name, for pronouns, and for sexual orientation, there's no drop-down box. It's just a blank and you fill it out as you see fit. That's one of my favorite things about our intake forms, because people will, if given the option, people will self-identify in so many different kinds of ways, as opposed to like gay, straight, bi. Questions I know we have. These are some resources. Again, I'm going to share these slides with you all. And I also have some textbooks and stuff that I'll grab and show you that I really, really like to use. I refer to them a lot. Citations, if you need ever to write a paper and you want to use my stats, feel free. Here's all the citations. And then this is, if you want to keep in touch with me, I'm so happy to continue answering questions via email. You can also connect with me on all the different social platforms. Don't judge my TikToks. And I also have a blog as well. So again, you're welcome to contact me on any platform, send me an email. And with that being said, let's do our last maybe 20 minutes and take some questions.
Okay. First question, when should people start getting tested for STIs, STDs, HIV? Should it only be after someone becomes sexually active, or do you recommend a certain age?
No, any age. So after you become sexually active, and preferably after any new partner that you don't know. So if you're 16 and you're having sex, that you should be screened for STIs. If you're 90 and having sex, you should be screened for STIs. And then, for example, if you have a new partner or if you're not in a non-monogamous relationship, you should be screened preferably at least after each encounter.
Is there a syphilis vaccine? Sorry.
Syphilis vaccine?
Yeah.
No, I wish there was. But syphilis, when you do catch it, you have to be looking for it. You have to check the blood. You have to know what to look for. But it's very easy to treat with just one big old shot of penicillin. And it hurts like hell, but your syphilis is gone.
Thank you. Our next question is, does birth control prevent ovarian or endometrial cancer?
It doesn't prevent it, but it prevents the risk. So estrogen levels are going to be suppressed on birth control and with pregnancy. So nulliparity or never having children is actually a risk factor for cancers. A lot of people don't really know why, but just that hormonal balance of suppressing estrogen through pregnancy or through birth control has a beneficial effect on your risk for cancers. But if you never take birth control in your life and you never have a baby in your life, that doesn't necessarily mean that you will develop cancer. It just means that your risk is a little bit higher because of what's called unchecked estrogen all throughout the lifespan.
Do people in medical school get sensitivity training for working with queer or trans patients, specifically in regards to using inclusive and affirming language for their trans patients?
Yeah, that varies depending on where you are. So I know a lot of programs do really, really good jobs training and educating their students on this. And I would say the majority, though, probably don't, or either you'll get like this, like a 1-hour lecture, and then you call it a day. So I would say that there's a big need for this kind of education in nursing, medical, PA programs, dental program, honestly, everything. I mean, really. So it just depends. It's not anything that is curriculum. So, there are curriculums for certification that, if you're a medical school, you have to teach this, 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 and this to be accredited. There's no requirement for LGBTQ training or health sensitivity, anything like that. So whether or not you get that is largely dependent on what school you're going to go to.
Actually, piggybacking off of that, how much of this material were you taught in your PA program in Alabama?
I learned most of all this through working here with my fantastic supervising physician, Dr. V. We learned a lot about STIs, a lot about HIV, a lot about cervical paps, but kind of those more nuanced things like anal pap smears and PrEP and PEP and different kind of STIs to look out for. I didn't really hear a lot about that. And we certainly weren't taught how to handle trans hormones.
We have a question about the mechanisms that the drugs that you mentioned use to stop HIV replication.
Cool. I will, I actually have a diagram for this, a little model. So if you'll give me literally 2 seconds, I'll run next door and grab it, okay?
Awesome, thank you. And just for all of our students who are still in this chat, now is a great time if you want to go onto our website and quickly comment on how you thought this session went with our speaker, Asia Sullivan. So you can go to www.prehealthshadowing.com and click on Asia Sullivan's profile page, and you will see all of the comment. You can rate is greatly appreciated.
Okay, so this is a little model that I use, or actually, I was just telling you guys that I had to learn almost all of this from my supervising physician, Dr. V. This is Dr. V. They're asking really awesome questions about PrEP and about HIV and everything. Can you guys hear us?
Yeah.
Yes.
Oh, perfect.
Oh, no, I can hear you too. Perfect.
Yeah, so we're asking questions about HPV. The most recent question was how medication stops, how does it work to stop the transmission of HIV? So we were talking about this little model, but I feel like it's probably a lot of detail. Do you have a quick answer for how you would say that?
Yeah, so each, where's the camera? Yeah, so each medication acts differently, depending on which medication class it belongs to. Today in 2020, we have a really, really wide group, many groups of different HIV medications that all are really, really well tolerated. And they all act and try to inhibit the replication cycle of a virus. Yeah, so the virus, what it does, it attaches to subpopulation of white blood cells in the body, the so-called T cells, the CD4 T cells. It goes inside of the cell and it takes its own genetic material and it incorporates it into the cell's genetic material. And basically what happens is that the cell uses its own machinery to replicate the genetic material of the virus and to build viral proteins, out of which new viral particles form and they get released right into the body. That's how the virus multiplies. The virus basically hijacks the cell's own machinery to produce more DNA and produce more proteins. And depending on the type of drug we are using, they inhibit the virus in its replicating process.
And different steps along the way.
Yeah. Now, the reason is, so you might ask, okay, so now I see how the replication of the virus is being inhibited, but how come we can't eradicate the virus completely from the body?
That was a question.
Yeah, and the reason is, the answer to that is the unfortunate aspect of the HIV infection is that even if we suppress the replication of the virus completely, that piece of DNA, the viral DNA that has been built into our cells, that stays there forever. And we can only potentially get rid of all HIV in the body if we kill all those cells, our own cells, our body's own cells, that contain HIV viral genome in it. Does it make sense?
Yes, thank you so much for that explanation.
Yeah, I mean, I hope that this is it's super, super complex. So, we are trying to explain to you guys in a few sentences things that physicians take days and days of studying to understand, right?
They said that makes sense.
Yeah, okay.
I showed him that same. So Dr. V usually presents this PowerPoint with me. So I showed him the one that we gave UC Davis. So we talked about, everything.
Perfect. Do you guys still have questions?
Yes. If you get tested negative for HIV, do you still need to get tested each year if you have no exposure after that?
Well, so the two points here. So depending which HIV test you're using, the most modern HIV tests, they're very accurate. They actually have a so-called window period of 10 days, meaning they can look backwards 10 days approximately in time. And in case you had no exposure to HIV in the past 10 days and you have a negative test, then you're negative, right? In case you have zero exposure, then there is no reason to be retested, right? We usually, whenever we have patients come to us once a year for their annual checkup, their full physical, we don't even ask them, we just check them for all STDs, right? Because most people will have had at least a few sexual encounters in their, reproductive years throughout the year. And even if they feel sometimes that, oh, that was nothing, just a little something, I don't think anything happened there. The best way is to be, to be safe and then just go ahead. And the testing is so easy. Mm-hmm. I always tell my clients, my patients, there's no such thing as being over-tested for STDs. You want to know.
Yeah. Someone said, Asia said that when you're undetectable, HIV isn't necessarily flowing through the bloodstream, but where are the HIV infected cells? This is $1 million question. Yeah. If you ever find the answer, you're going to be rich.
Yes, so those cells where the HIV virus hides, we call it the reservoir. And there are current clinical trials actually that are being conducted that have as a goal to cure HIV, to not just suppress the viral replication, but to target those cells specifically where HIV is hiding. Now, those cells there's a bunch of different theories, and it's not 100% understood where exactly those cells are, but we suspect that some of those are actually in the hematopoietic system and also in the central nervous system, in the brain and in the spinal cord, the so-called microglia cells. Those are supporting cells, tiny little cells that are surrounding neurons in our brain. They might be contributing to this. Some people say the testicular cells and just a bunch of different cell types throughout the body that we might not even know about. Now, people who have had people who get exposed to HIV and they establish HIV infection, right? And they become patients who carry the virus. The longer we wait until treatment, right, viral suppression, the higher the chance that this reservoir is going to be big, and it's going to have a lot of cells that are going to have viral genetic material in them. So once it comes to a cure, when we would want to eliminate these cells, then a bunch of cells need to be destroyed, and the treatment is going to be much more aggressive for these people. That's why whenever we diagnose someone with HIV, we always say nowadays, start treatment right away, right? To start suppressing the cells right away to minimize the size of the reservoir in the body where the HIV virus is going to be hiding.
What are some major side effects of PrEP?
Good. So there are currently two medications that two medications that have been approved by the FDA for PrEP. The first generation was Truvada. The second generation is an improved formulation of Truvada that is called Descovy.
That they learned all about.
Yeah. So the major side effects of Truvada, the first generation PrEP, is that it can sometimes bug the kidneys. It happens very rarely, but it can. So that's why we always have to keep an eye on the kidneys throughout the time when you're taking Truvada. And it can also cause a little bit of a weakening of the bones. That is usually not an issue in young and healthy and physically active individuals. If you wanted to give PrEP to a person who is a little bit more elderly, up in age, maybe postmenopausal women, they have a little bit more kind of like brittle bones and bone issues, then you would have to take that in consideration. But usually in young and healthy young people, it doesn't play a significant role. And then this Descovy is the second generation form, is a little bit more kidney friendly, a little bit more bone friendly, but it has been shown in some clinical trials that it causes some weight gain. Right, the weight gain can be a few pounds in some people, a little bit more, in some people not at all, right? But we have seen that that is something that we just don't see with Truvada that much. But I have to say, though, that both of the medications are really well tolerated. We have hundreds and hundreds of patients who are taking PrEP, either Truvada or Descovy, and the times when they are complaining about any kind of side effects are almost non-existent. It's very, very rare. Very well tolerated medications.
Asia, do you have any advice for people that are going through PA interviews?
Yes, and for sake of time, please shoot me an email or either go to my blog, coutureandclinic.com. I have all these interview tips, and I'm happy. Yeah, go there and you'll see them.
Okay.
Yeah.
Last question. Do you have any advice for the pre-health students, both of you, to any pre-health students out there?
Go out there and change the world and kick butt.
Yeah, I mean, I think just the fact that you all 100 of you, I'm shocked. I thought this was going to be like 10 people. So I think the fact that you showed up today means that you're already kind of doing those things that you need to do, getting your exposure. These are virtual shadowing hours. So these students can't shadow because of COVID-19.
Oh, okay.
So that's why we're doing this. And they shadow different specialties every week or so. So you're already doing the things, right? Obviously you want to keep your GPA up and practice for standardized testing and stuff like that. But I think one of the best things you can do is these kinds of experiences where you can say, hey, I learned about these different areas of medicine, and I really kind of fully understand what it means to be a provider. And that's what, I want to do that. I also have tips about that on my blog as well.
Yeah, Asia is the expert in that.
Yeah. All right. Well, is that it?
Yes. Thank you so much.
Yeah, totally.